Thank you so much, Ruth. Thank you. Good morning, everyone. For those of you that I may not have met yet, my name is Deirdre Calvert. I do go by Dee, and I'm the director of the Bureau of Substance Addiction Services at the Massachusetts Department of Public Health. I am a middle child of 6. I talk fast. I will do it. I will get us through. I'm also a licensed social worker, having worked as a clinician and a provider in the field of substance use disorders and co-occurring disorders for more than 30 years prior to coming to work for the state. I just want to say thank you so much again for asking me to speak. I'm always so honored. BSAS is so grateful for all the providers, especially the OTPs, for providing life-saving care every day and even during constant regulatory changes over the last few years. As many of you know, methadone access is a topic near and dear to my heart, not only as the director of BSAS, but also as a former OTP clinical director. I am thrilled to be able to stand before you all this morning at the 3rd MASAM conference to discuss the progress and trends we've seen in efforts to expand methadone access in Massachusetts in the year following the implementation of the final rule. Methadone is a gold standard of care and treatment for opioid use disorder, but significant barriers to access remain. While Massachusetts has 55 community-based OTPs serving 24,000 individuals, there are an estimated 96,000 individuals in the Commonwealth with an opiate use disorder. As I will discuss, while this year we received some encouraging news about decreases in overdose deaths, we know that disparities continue in both death and access rates exist and persist. Disparities in access are due to a legacy of a racist war on drugs policy and a war on drugs mentality. At present, the current system is not meeting the needs of people with opioid use disorder and is not engaging the communities of colors who have been disproportionately affected and impacted by OUD. Today, we will spend time reviewing Massachusetts' progress in expanding methadone access. It is critical that we, as partners in and champions of this work, remain committed to acknowledging and addressing these disparities and to moving forward a system that gives individuals more autonomy and empowers clinicians to utilize their best clinical judgment. To begin, I'll start with providing a general understanding of the treatment programs that BSAS licenses, contracts with, as well as a recap of recent news and overdose death data trends. I'll then overview recent state progress in methadone expansion, review trends in OTP data, and conclude by discussing BSAS's plans for the future. It's an action-packed morning. So, whew, I have no actual or potential conflicts of interest, but I do want to take a minute just to say thank you to my amazing BSAS team, especially Jen Babich, Mike Gurney, Zakia, Jacob, and Abby in particular for bringing this presentation to life. I did not do this. They did this. So thank you. Thank you, guys. They make me look good. All right. Okay. So BSAS is the federally designated single state authority for substance use disorder. This is SSA. Every state has an SSA. BSAS develops, implements, and oversees prevention, treatment, harm reduction, and recovery support services throughout the Commonwealth. BSAS provides training and technical assistance to the workforce and promotes non-punitive approaches to substance use. And while today we're going to focus on OTPs, I want to briefly review the broader BSAS treatment landscape. Currently, BSAS licenses and regulates over 500 treatment programs, which together serve youth, young adults, pregnant people, adults, and families. Our continuum of care follows the nationally recognized ASAM continuum from 0 to 4.0. And as of August 1st, 2025, BSAS licensed and contracted treatment programs, including 80 programs that provide 24-hour diversionary services, including ASAM levels 3, 5, 3, 7, and 4. Over 250 outpatient service programs, including office-based opioid treatment programs or OBOTs, as well as 20 plus office-based addiction treatment programs and OBATs that we contract with. We have, as I said earlier, 55 community-based OTPs, plus 5 mobile units and 6 medication units. We are in 25 penal facilities that offer access to medications for opiate use disorder, or MOUD, and we have over 100 residential treatment programs, including both transitional support programs, as well as longer-term programs that range from 90 days to 6 months. So as you can see, OTPs represent only one critical piece of the broader, more expansive treatment system. So, overdose trends. This work to expand access to harm reduction, prevention, treatment, and recovery services have had an impact. So as many of you are likely aware, according to the CDC data released in May, opioid overdose deaths in Massachusetts have decreased by 36.3% in 2024. So let's just take a minute, 36.3%, falling to the lowest levels in over a decade. This is also 16% lower than the national average. So we're doing better than the national average. I'm a social worker, so I always have to think about my math. So yes, 16%. So this is phenomenal. On BSAS's publicly available data dashboard, which I would encourage everybody to go on and tool around and play with, you can see that confirmed and opioid-related overdose deaths through December 2024 mirror the downward trend as reported by the CDC. Expanding harm reduction services has been crucial to overdose prevention, and as the BSAS dashboard shows, Massachusetts surpassed the naloxone saturation benchmark in 2024, reminding us of the importance and the impact of this work. So in addition to expanding harm reduction access, MOUD access has also increased statewide. So over the last 4 years, over the last 5 years, OTP access has grown from 44 OTPs in 2019 to 55 community-based, 5 mobile OTPs providing access across the state. There are also 6 medication units, including 3 that opened in the last year in Boston, Worcester, and Spencer, and 2 most recently in Brockton and in Hyannis. Additionally, a second mobile stop has been added in rural Western Mass and Palmer. Another mobile unit will be available in Provincetown, tentatively in early November. There are also 25 penal facility locations representing the majority of penal facilities in the state, now offering access to MOUD either directly or through the use of a community-based OTP. Massachusetts now requires all inpatient withdrawal management programs to become OTP certified to provide access to methadone. We strongly encourage these programs to induct patients, move them on to maintenance, and provide individualized treatment and education on all forms of MOUD, including its risks and benefits. There are now a total of 46 24-hour diversionary withdrawal management services programs providing access to all forms of MOUD. Broadly, many OTPs across the state are working to better meet the needs of patients. This includes engaging in innovative alternative service delivery models to meet patients where they're at, the use of telehealth, mobile methadone units, medication units, and delivery of methadone directly to patients at places like skilled nursing facilities. Some OTPs are also moving away from the traditional operating hours of 6 a.m. to 2 p.m., which I did for many years, to meet better needs of the patients. So before diving into the data, I want to review key updates to the final rule guidance that have been implemented over the last year. So in February 2024, HHS through SAMHSA published their final rule, which updated existing regulations for OTPs. These updates were intended to increase access to MOUD and retention and care through promoting flexible, patient-centered care, emphasizing shared decision-making, reducing barriers to accessing care, and removing stigmatizing language. Regarding the implementation of the final rule, BSAS issued an initial blanket waiver and guidance letter in April 2024 in order to align, in order to align with the changes in the final rule. This guidance was later revised in July of 2024 and most recently revised for a second time a few months ago after receiving further clarification from SAMHSA. That was in July of 2025. Broadly, these revisions address 3 primary areas which are important to expediting OTP admissions. First, we received updated guidance clarification from SAMHSA around initial screenings by registered and licensed practical nurses. Generally speaking, SAMHSA has clarified that RNs and LPNs who have patient assessment within their scope of practice and authority, as established by the State Board of Nursing, can conduct the information gathering and assessment portion of the initial screening examination and relay that information to practitioners for decision making. Second, there has been clarification around the use of telehealth for full methadone examination. In their response, SAMHSA clarified that the full examination may be completed via telehealth prior to treatment with methadone with certain caveats. Finally, a BSAS waiver was issued for take-home locked container requirements. A blanket regulatory waiver was issued for the requirement that take-home medication be dispensed to patient in locked containers. OTPs must continue to maintain procedures to mitigate the theft or diversion of take-home medications, as well as ensure that each individual take-home dose is packaged to reduce the risk of accidental ingestion, and the patients are educated about the importance of safekeeping of their meds. Broadly, BSAS is working to encourage flexibility in programs and service delivery, and our hope is that this increased focus on patient-centered care will improve access to OTPs. So that being said, we believe that we are seeing increased flexibility, improve OTP access as seen through BSAS data. As I'll review, since the implementation of the final rule, we've seen increases in new enrollments, improved uptake of take-homes, and increased utilization of outpatient treatment and other encouraging trends. So what we see here highlights a few of the useful pieces of information about the growth of the OTP system. First, we can see that in the year after the final rule from April 24 to March 25, there were over 5,000 new individuals entering an OTP. Then at the same period, we can see that the total monthly census rose by 667 individuals, a nearly 3% increase. The numbers are different because the census also reflects people leaving treatment. So we have 5,000 people come in and there's people leaving as well. The increase, though, in new enrollments may reflect improvements in access to telehealth, take-homes, and more inductions occurring outside of OTP, such as in corrections and withdrawal management settings in hospitals. As we gather more data, we'll be able to look at the year-over-year changes and trends. As mentioned, we look forward to learning about whether increased program flexibilities will attract more people to methadone treatment within the OTPs. And we know a dominating factor is reducing barriers to treatment, especially by providing each patient with a number of take-homes that they're now able to have, thereby reducing their need to be present at the clinic daily and improving their lives significantly. This graph here shows the length of engagement for patients currently active in OTP systems as of August 2025. What we can see here is the average length of enrollments in an OTP varies greatly. In the largest group, almost 38% of patients stayed enrolled between years 1 and 5. Then we see a little over 31% of the patients who were enrolled over 5 years, with just slightly more being enrolled at 1 year or less. In addition, of the OTP patients discharged in fiscal year 25, roughly half had a length of stay of 6 months or less. This may speak to the need for our OTPs to focus more on patients entering into treatment and finding ways to engage them, including reducing any barriers to continuing treatment, take-home access, and any other barrier they may face. BSAS will continue to elevate this data and support OTPs as they review their own data and change policy or course as needed in order to keep patients in treatment. BSAS is constantly evaluating take-home trends within the system and has the ability to review take-home trends and numbers per OTP and can compare it to the state take-home averages. Looking at the period spanning April 24 through August 25, data shows that the percentage of OTP patients statewide that receive any number of take-homes has increased drastically, reaching a peak of nearly 69 patients receiving some form of take-home medication in July of 2025. And while the graph on the slide shows data through August, I'd like to note in a more recent report that it is as of this week, the number is actually 75%. Yeah, so this is just amazing. For comparison, prior to COVID, only 16% of patients received any take-home medications. Yeah, this is, yeah. Just as a little side note, I'm going off the notes, sorry guys. When I worked at an OTP, I used to say, like, before COVID, you could literally pick me up and drop me in an OTP and it'd be almost exactly the same. The rules hadn't changed. And then the rules have changed drastically since COVID. So it's wonderful. It's critical to note, however, that patients who receive any amount of take-homes, and this could be anywhere from 1 to 28. So for example, we can see among active OTP patients, over half of the patients attend clinic 5 days a week or more. This data, including information by agency and OTP, will be critical as we continue to promote greater uptake of take-homes. Here we can take a look at the referral source for active OTP patients. We can see the vast majority of patients, over 80%, were referred by a non-medical provider either themselves, a friend, a family member, or someone other than a medical professional. That is a number that we've seen increase over years. Also notable is that 40% of active patients did not have a prior history of any kind of MOUD prior to enrollment. Again, we are hoping that the new flexibilities and increased focus on patient-centered care will attract new patients to OTPs. On this slide, the data is focused on race and ethnicity of active OTP patients as of August 25. We can see the majority of active OTP patients, or about 87%, self-identified as white. And that's also the same as when I was working at a clinic from 97 to 2001. You can see also roughly 82% of the active patients in the census identified as non-Hispanic Latino. You'll also see that there's some unavailable race and ethnicity data. It's unclear if patients refuse to answer or if the staff isn't entering the data correctly or at all. This data reflects what we know, which is the minority race groups are often underrepresented in OTPs. These disparities can be seen at national levels as well. A 2022 CDC report noted that among the 4% of adults who need OUD treatment, only 25% received recommended medications, while around 30% received treatment without medications. Higher percentages of white than Black or African Americans or Hispanic or Latino adults received any treatment. This data is also a call to action. We can see that there is a need for expanded communication about the effectiveness of medications for OUD, and we encourage clinicians and other treatment providers to offer a range of evidence-based treatment, including medications for OUD. And while we hope that the updates to the federal regulations will reduce barriers to treatment and make it even easier for anyone to receive methadone, we will continue to advocate for further expansion and access to this treatment. Additionally, demographics differences in OTPs suggest specific areas where BSAS can continue to focus on interventions and decrease inequities. For example, we are continuing to work with long-term care facilities to increase access to methadone for the aging population. We also funded language and culturally specific liaisons through federal grants to better reach historically marginalized populations. Still, we know there's more to be done, including specifically to decrease racial inequities in the access to OTPs. So, OTPs at a county level. Here we take another quick look at active OTP patients, this time by county. As of August 2025, we can see that Hampden County, Worcester, and Bristol represent the 3 counties that have the highest number of active patients enrolled in treatment. Hampden, for example, has over 3,700 active patients enrolled, while Worcester has 3,500. This is notable distribution when we take into account that Hampden's population is at 460,000, while Worcester's is at 860,000. So there are not enough methadone slots in the large cities. In comparison, Suffolk County has an estimated population of 1.53 million people, and they are in the 6th spot for access to OTPs. When viewed at a rate per 100,000, the western half of the state seems to have the highest rate of active patients. However, the rurality, is that a word, rurality? The ruralness of an area, makes a difference on accessibility of treatment as well. With data from both our dashboard and the collaboration with research at Tufts University, including Tom Stopka and his team, we've been able to visualize statewide walking and driving access to OTPs. The map shows that there are several areas, mostly in Western Mass, where individuals are more than a 30-minute drive to an OTP. Tom's research further identified specific areas in Worcester and Springfield, and in the westernmost part of the state where the nearest OTP was more than a 30-minute drive away were individuals who had fatally overdosed. Tufts also found that 98% of opioid overdose decedents have been within a 30-minute drive to OTPs, and 80% were in a 15-minute drive. 32% of decedents were in a 30-minute walk, and only 9% were within a 15-minute walk of an OTP at the time of their death. This underscores the need for both expanded MOUD access and transportation across the state, including in suburban and rural areas. The results are really important, given that we know that the most rural areas of our state have also become the highest for overdose deaths. So a quick recent review of BSAS service utilization data suggests that expanding access to MOD is also impacting other inpatient levels of care as well. All right, so first in looking at withdrawal management, what we used to call detox, which we used to call ATS, which now call withdrawal management services, like to keep you on your toes. Over the last 10 years, we can see that there has been a significant drop in admissions. The majority of this decrease is due to a drop in the ASAM 3.7 level of care, detox, ATS, whatever we want to call it. All right. We can also see that during roughly the same period, the admissions to all MAT types increased since 2019. This has been due to both expansion of existing services as well as new models for the delivery of services. On this slide, we can view the two trends together. So while the withdrawal management 3.7 admissions have decreased, admissions to MAT has increased, like I said. The trends that we are seeking here track with efforts to expand outpatient delivery of MAT services, including the support of mobile vans, medication units, the use of recovery coaches, outreach workers to increase engagement, access, and wraparound services. Oh, there's a little yellow thing. Yep, see. So going down, going up. Okay, so looking to the future. There we go. To this end, BSAS is continuing to work on guidance and resources to assist providers in coordination of OTP access to methadone access. Specifically, BSAS is contracted with JSI to offer training and technical assistance for OTPs, including through trainings on various topics like infectious disease testing, words matter and stigma, and regulatory updates. I encourage everyone to visit the OTP training website and learn more about the TA and other resources available. BSAS is also planning to publish several materials related to the topics I've covered today, including the supplemental report on geographic access, which I mentioned, which includes 3 addendums focusing on Suffolk County, Worcester, and Springfield, where OTP service locations could benefit the population. We look forward to utilizing these recommendations from the reports to better meet the needs of MOED in areas most impacted by overdose and opioid use disorder. Guidance outlining best practices for how hospitals should coordinate with OTPs to ensure continuous access and care for patients with opiate use disorder, and protocols for non-OTP providers to administer methadone for up to 3 days, to manage opioid withdrawal or start maintenance treatment while arranging for ongoing care. This has been done in partnership with BMC's Graken Center for Addiction and Training and Technical Assistance. Furthermore, BSAS is working to implement changes to mandated reporting and family care plans related to infants with prenatal exposure, which we are really excited about, of making a dual path if you want to know about that. BSAS is committed to remaining flexible as we evolve our approach to substance use treatment. One new effort I'd like to highlight is the START program, which is the Stimulant Treatment and Recovery Team, which is an outpatient treatment program for individuals seeking support around the use of stimulant substances. The START program engages, START engages multidisciplinary providers from primary care, behavioral health, and case management services. And the care can include emergency pharmacological protocols, a contingency management program, the provision of cool down spaces and exercise programs, as well as the collaboration on holistic treatment plans. There are currently 4 START programs across the state, including Boston Medical Center, Healthcare for the Homeless, High Point Treatment Center in New Bedford, and Center for Human Development in Springfield. A 5th program is employing a START Light program in Lawrence. All right. Okay, we're getting there. All right. Another of our ongoing efforts has been work to track that is an ever-evolving drug supply. We know more about our drug supply than ever due to the support of the Massachusetts Drug Supply Data Stream, or MADS, through the Brandeis University. In 2019, MADS has collected and analyzed drug samples for the purpose of community notification and to inform public health action. The presence of substances like xylazine in our drug supply underscores the ever-changing landscape and the need for programmatic flexibility to meet the evolving needs of people who use drugs. I'd like to also take this moment to acknowledge that all of this work continues against the backdrop of the current federal regulations and the federal landscape. And I just want to be really clear for BSAS that regardless of what happens at the federal level, BSAS remains committed to investing in work that we know works. Housing first, harm reduction, access to evidence-based treatment, trauma-informed care, and policies that uphold human dignity. So I just want to say thank you to everyone who joins us in this work. I'm always grateful to be here. And I think I finished on time. All right.